This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I'm sitting here with Dr. David Spain, one of our CSAP 17 authors, who's agreed to speak with me today. David, can you share with our audience a little bit about where you're located, your primary focus of your clinical practice, and maybe a little about how you spend your usual day other than talking to me?
Well, I am a general surgeon working at Stanford University at the Stanford Healthcare System. We're a large tertiary referral hospital. I sort of do we would now consider the classic acute care surgery practice. So I do trauma, emergency surgery, and surgical critical care. And I also have a decent-sized elective surgical practice. The usual day, I don't think there is such a thing. I think it's more usual weeks. So, if a week is 1 or 2 weeks a month where I'm either the acute care surgery attending, doing a lot of trauma and emergency general surgery, or a week a month where I'm the surgical ICU attending.
Well, thanks for that little bit. And I've asked you to share some of your thoughts about various conditions a surgeon faces in this world of acute care surgery or emergency general surgery. So we'll be discussing a lot of topics from CSAP 17 that are located in the elementary category, since we don't really have a category for acute care surgery or emergency general surgery yet. And as you mentioned, acute care surgery takes you into the world of critical care and trauma. So I'll finish with a couple of topics that touch that area as well. So many of the topics we'll be discussing actually come from CSAP 17 questions, and others are questions that many of the committees wrote and discussed, but they didn't quite make the final draft of CSAP 17. And I hope to pick your brain about all of these that a general surgeon may find themselves confronted with. So let's get started. And first, I know you've been involved in this, I guess we could call it an evolution, in trauma care into the world of acute care surgery or emergency general surgery. And the first thing I'd like to ask you, do you think both terms describe the same person? Or have we even progressed a little bit in the terms actually describe a different practice pattern?
I think there's slightly different practice patterns, but I don't know that we should get caught up in the semantics too much. I guess the definition of a full acute care surgeon is somebody who does trauma, surgical critical care, and emergency general surgery. I think that practice model is most applicable to level 1 trauma centers, maybe some level 2 trauma centers, but it doesn't really necessarily fit in other settings, like many level 2 trauma centers or many rural places, where the preponderance of what you're going to be doing is emergency general surgery. Some people get very emotional about the terms, and I don't get so concerned that much. I think to me it's more about who is interested and dedicated towards taking care of patients with emergency surgical problems, whether it's trauma or general surgery. And if you're committed and willing to, get up in the middle of the night, take care of sick surgical patients, I don't care if you're the full-fledged, acute care surgeons with all 3 components in your practice, or if you're doing the preponderance of emergency general surgery. If you're sort of made that commitment to taking care of sick patients, I think that's the most important thing.
And as you see it, is this a viable surgical role for our trainees as we are finishing them today?
I think so. The surrogate markers, I think, are there. The number of trainees going into surgical critical care, which I think is, for many of them, the pathway into acute care surgery, that number is going up every year. And now pretty much 1 out of every 6 graduates in the United States in general surgery is going into surgical critical care now. So I think that the popularity of acute care surgery has driven a lot of the interest into surgical critical care fellowships. And I think there's just certain aspects about the practice that interest people today. And I think it's really the team-based care and the the team model of having an acute care surgery service and working together that I think is appealing to trainees now.
It's interesting you mentioned the surgical critical care training as the entry into this clinical practice, and it's something that I have noticed as well. But let me ask you then, do you need extra training in surgical care, not critical care, but surgical care, or does a solid general surgery training fit the need when you go and try to satisfy the role of the acute care surgeon or emergency general surgery?
Yeah, I think depending on where you've trained and what your skill set is, I think most well-trained general surgeons coming out of residency programs should be, able to handle the vast majority of surgical emergencies and emergency general surgery cases we're going to see. I think there's a few, high-end sort of complex cases, emergency cases that might benefit from additional training. But I think, I would hope the majority of people finishing a solid general surgery training program would be able to handle most of the emergency general surgery problems they're going to see in practice. I think there might be some special things where you might want to get additional experience. And I think some of the, issues around research and specializing in a particular area might be reasons to pursue additional training. But, I think for the most part, a good general surgery resident should be able to handle the majority of these problems.
With the increase in the applications to surgical critical care to fulfill this role, is there a decrease in the number of acute care surgery training programs that are out there today?
So that number is actually going up slowly. I think there's 3 or 4 more acute care surgery fellowships coming online this year. And so that number is pretty close to 30 right now. I'd like to see it go up, but that might be getting near the ceiling. I don't know that acute care surgery fellowships are going to increase dramatically in number unless and until there's some sort of official recognition or certificate for that training.
That leads me to my next question, which is related to saturation. And you kind of mentioned that the role is best in level 1 trauma centers for the acute care surgeon. Are we really playing to the needs of the institutions? And once saturation is achieved, positions for our trainees are going to become less available?
Yeah, I don't know where that end point is right now. With the consolidation of healthcare systems and the employed, surgeon model being predominant now, I don't know. I think definitely there's definitely a saturation at level 1 trauma centers, right? There's only 110, academic teaching hospital centers with, so much work. But I think the next thing you're going to start to see the acute care surgery model really start to populate more level 2 trauma centers. I think in most level 2s around the country, there's usually somebody who's a general surgeon who does trauma and emergency general surgery, but not necessarily critical care. I think a lot of community level 2s that's done by non-surgeon intensivists. And I think that's the next place you're going to see the acute care surgeons really begin to populate is these level 2 trauma centers and working as an employed physician. But I don't know how much more that market is. I think it's reasonable. I think at some point you're going to see some saturation, right? Yeah, I think we're getting close to like 250 surgical critical care fellowship slots in the country, and that's probably getting near the ceiling, I think.
When you and I started this ICU stuff, we got a lot of pushback from our medical colleagues who said, what did we think we were doing? And if we expand that into the level 2s, won't we see the pushback re-emerge as a problem for our young candidates?
Yeah, I think that'll be the interesting thing, right? Because in many of those places there is an established group. On the other hand, ownership is 9/10 of the law. So if you're the surgeon getting up in the middle of the night, admitting trauma patients or taking care of critically ill general surgery patients, and you have the requisite training and you're there in the middle of the night and you're willing to do it, I think that's going to carry a lot of weight. But it would be a major sort of practice shift. And I think it's one of these things that'll probably happen gradually over time. You'll have hybrid teams where there's surgeons and non-surgical intensivists, and eventually I could see those, being taken over and run by surgeons.
So in your view, the future of this kind of service is good?
I think so. I think for the foreseeable future, I don't see the need going away, and I think as there's continued specialization amongst general surgeons and the need for somebody who's willing to answer the call in the middle of the night and take care of that critically ill patient with a general surgery problem or trauma problem, I don't see it going away in the near future.
Well, let's talk about some of these acute surgical problems that an acute care surgeon or emergency general surgeon will face. So adhesive small bowel obstruction has undergone a lot of changes in management over the last, I would say, 5 years. And I'm asking a few of the CSAP authors to weigh in on this, so you're not the first. But are you a user of the contrast challenge? And if so, how do you do it, since it seems like everybody has a little different twist?
Yes, we are users, and I do think it's helpful. Our typical way is, we admit somebody with adhesive small bowel obstruction. I usually get an NG tube in, get them decompressed for a while. Usually the next morning, we administer 90 mLs of contrast. Why we pick 90, I don't know, or why not 100, but it's 90 mLs of gastrografin. And then we shoot a KUB at 6 hours, between 6 and 8 hours. And if the contrast is in the colon, we take the NG tube out and let them have clear liquids. If we don't see contrast in the colon at 6 or 8 hours, we get a second film at 24 hours. And then if there's no contrast in the colon, then by 24 hours, then we start talking to them about a trip to the OR.
And when you say you get a film, is that just a flat plate of the abdomen?
Yes.
Okay. How often, when you see no contrast, do you not only convince the patient to go to the operating room, but you convince yourselves to take the patient to the operating room?
Good question. I would say most of the time. I think if they're not clinically getting better, by now usually by the time you get that second film, you're at least 24 or 36 hours into the episode, and if things haven't clearly gotten better, then you're usually looking towards going to the OR, and then it's usually another 12 hours or so before you can get in the OR. So unless something changes, you're now usually 48 hours into it without any clinical progress. So I think that's a reasonable time frame to make a decision.
Another question that always happens at morning report is that patient with adhesive small bowel obstruction. Before you start your contrast challenge, somebody says, well, the radiologist says it's a complete obstruction, and maybe we should just go to the operating room. Do you think the radiologist is getting good enough, and our technology with imaging is good enough that we can make the determination between a partial and complete obstruction?
I don't think so. The number of times we've gotten those reads that say complete bowel obstruction or closed loop obstruction, and you see the report and you sort of freak out and run to the bedside, and all of a sudden, the patient looks at you and they're like, I'm fine, and then they start passing gas in front of you. I mean, it happens on a regular basis. So I do think the clinical assessment is really important. I do think there's a rare CT scan that's just so definitive, but you've got to have, classic sort of, again, this is all short of clear signs of the CT scan of there being ischemia, right?
Right.
But, occasionally you'll have that classic, you'll see a clear twist in the mesentery and an obvious closed loop obstruction, but I'm taking a guess here, but I would say at least 50 to 75% of the time when the CT scan's read as a complete bowel obstruction, the patient opens up within 12 or 24 hours.
Well, that's small bowel obstruction. Let's talk a little bit about large bowel obstruction, and specifically about sigmoid volvulus. All our books say that initial treatment with decompression remains the mainstay, and certainly sigmoidoscopy is probably what you and I used for years and years. We're seeing some of these patients being managed by our GI colleagues first. Is that happening at your institution?
Well, we are usually getting consulted on them, but I will say that frequently we abdicate the endoscopy to GI, which I think is not necessary most of the time. And even for a lot of these patients, a rigid sigmoidoscopy actually works pretty well, which is a dying art. Like, nobody does rigid sigmoidoscopies anymore, and actually it's a very helpful procedure that, in this case, can frequently help decompress them.
And they like that long, skinny tube at our place. How about at your place?
Yeah, they'll frequently place them, but then they usually fall out right away. So.
Okay. And when they fall out, do they recur right away? Does the patient have a recurrence right away?
Usually not. They'll usually have, symptomatic decompression and be all right for a while.
What's your usual management scheme after they've been decompressed?
Most of these patients, they're kind of the classic patient, right? They're usually elderly. They're usually frail. I do think that the data is pretty reasonable that the recurrence rate is going to be pretty high if you don't operate on them. And so it's really the next thing that has to happen is a good, sort of goals of care discussion with the patient and their family, and a strong assessment of their, fitness for surgery or not. But if they're, reasonably fit candidate for surgery, usually you try to do the surgery in another day or two. A little bit depends on how their KUB film looks. If they're full of stool, I may try to prep them a little bit, but it's interesting. A lot of these people are actually, not that. They don't have a big, heavy stool burden. And so a lot of them you can just take to the OR without a bowel prep and do the resection.
So in that frail patient, David, do you remove the tube and see if a recurrence occurs?
Well, they are, right? If you remove the tube, the recurrence rate over several months is going to be at least 50%. And then it's a question of a discussion with the family, like, and the patient. Is this just going to be, are we just going to try and symptomatically treat them if it recurs? Or, if they're a decent surgical candidate, then I think you should just get on with the operation and get it done. I will say the sigmoid volvulus case, they're usually pretty straightforward, right? You make an incision, and that redundant colon pretty much just jumps out of the incision at you. And the two ends that you need to anastomose are usually, sitting right there. So the sigmoid volvulus cases are usually a lot easier than people think they're going to be. So
tension-free anastomosis is extremely easy to accomplish when you have that sigmoid volvulus like that.
Yep.
Now that's sigmoid volvulus. Any thoughts on cecal volvulus? Is that something that we can decompress with a scope using our GI colleagues or not?
Yeah, usually not, right? That's very challenging. So I think if you have a clear cecal volvulus on CT scan or other imaging, then that's usually just an indication for an operation. Because I think the incidence of ischemia is much higher on and it's just really challenging to detorse those, with a scope. And then I think the leak rate after a right hemicolectomy is significantly lower than a left hemicolectomy. So I think in a cecal volvulus, they're pretty straightforward as a surgical candidate. You usually get them in the OR.
So let me push you on the cecal volvulus because I have an interesting recent case that occurred in one of our residents, and they presented with obstruction, distended cecum that appeared to be in the right upper quadrant, and we agreed that, we need to do something. And about 2 hours later, she passed flatus and felt great, and her belly was not distended. And subsequently, a diagnostic study demonstrated that she does have a floppy cecum, but she really just has a bascule and not a fully mobile cecum. What do you think we should do?
That's a tricky one. So the bascules are slightly different, but the same general concept is just sort of rotates up instead of up and to the right instead of over and to the left. And I guess the question is, again, this would seem to be a patient where, again, next time will you get lucky and will the patient detorse on their own the next time it happens, or is this somebody that should be set up for a laparoscopic, right hemicolectomy? I would probably push more towards operating just because I think, especially if you could do a laparoscopic right colon, I think that would probably be a reasonable option.
Well, a surgical resident, when you tell them you want to operate on them, they say no because they got too many other cases to do. So right now we're waiting and watching. So, okay. But it's an interesting twist. Well, let's talk about another acute problem that acute care surgery seems to own in most hospitals these days, and that's cholelithiasis. First case is you got a clear-cut patient who comes in with cholelithiasis, been having biliary colic. And do you have any strict criteria that you use to clear the duct pre-op, or do you deal with the duct intra-op? What happens at Stanford to that patient?
I think it all gets back to who you are and what your skill set is, right? So for me, I look at their LFTs, and if they're stone cold normal, and they've had biliary colic, then I just take them to OR and do a lap chole. I am not a routine intraoperative cholangiogram person. So then, normal LFTs or normalized LFTs and a clear-cut biliary colic, then I'm proceeding to lap chole. If there's any question, if they have stones in the duct, if it's not definitive on ultrasound or the like, what would happen most likely at our place would be the patient would get an MRCP, and if that was positive, they'd go on to ERCP. Occasionally GI is so convinced by the labs and the ultrasound that they'll just go right to ERCP, but most of the time they like to have some confirmation.
So the ASG guidelines play some role. That's the ultrasound findings, the bilirubin level, and the lowest bilirubin level, I think, is 1.8 in that sequence. Is that helpful?
Yeah, I think so, right? Anything less than that, it could definitely be, reaction to the cholecystitis and the like. But, I actually personally think the best thing would be if you had some question rather than an MRCP, that the patient get an EGD and an EUS. And if that's positive, then just proceed right to ERCP. But that's frequently hard to coordinate.
Okay. Well, let's move up the ladder and call it cholecystitis. And so now the diagnosis is made, and it's, let's say it's 7 o'clock in the evening. When do you go to the OR? Do you go that night? Do you go the next day? Does the patient profile make a difference?
So the short answer is it sort of depends on what the wait list looks like. I kind of have a rule in my head. I'm not sure it's a great idea to be doing semi-elective lap choles at 1 in the morning for a variety of reasons. So, I kind of, if it's before 10 p.m. and I can get in the OR, I will probably do a lap chole in the early evening. Again, I'm not sure I'd do it at 2 in the morning. But, I think it's very reasonable in those cases to try and do it the next day. Again, assuming you have a mechanism on your OR to get that patient on the OR schedule the following day and get that case done at a reasonable time.
So comorbidities doesn't matter, or if you have an elderly patient, you usually wait till the next day?
Yeah, I think some more so, right? Yeah, even 10, 11 o'clock at night, if I've got a, healthy, straightforward, person that I think has got early acute cholecystitis, it's going to be relatively straightforward. Yes, do them in the evening. But if you got somebody with a lot of comorbidities, I think waiting 12 hours until the light of day and having more help around is probably a very reasonable thing to do.
Used to be that we had a cutoff if the symptoms were more than 72 hours. We would try not to take them to the operating room or not to try to do a cholecystectomy. More and more articles are coming out that may not be appropriate anymore with our laparoscopic techniques. How do you feel about that?
I think most of the data now would say certainly up to 4 days of symptoms at the risk of complication and conversion to open. It doesn't go up until you hit at least 4 days, and some data would even suggest maybe it's as long as 7 days before you start to see an increase in complications and conversion rates. So I think somewhere in there is the answer, 4 to 7 days. Some of it depends on the patient, right? Are they morbidly obese? Do they have comorbidities? Are they a thin patient with a straightforward, and what does the ultrasound look like? So I think there's a sort of number of data points you have to incorporate. I think certainly if you get out to 6-7 days into it and it looks like it's going to be hard, and the chance of converting or having a difficult case looks like it's reasonable. I think in those people it's not unreasonable to sort of admit them, put them on antibiotics and see how well they respond. And some of these people, 24 hours later, they look great. The pain's much better. They're feeling better. Their white count's normalizing. I think in those situations, if they've been symptomatic for 5, 6, 7 days and they respond well to your initial treatment, I do think in some of those people it is reasonable to cool them off and do their WAP chole in 6 or 8 weeks.
Okay, well, there's a question about that tough, inflamed right upper quadrant mass associated with cholecystitis in CSAP 17, and it's fascinating because it brings up the issue of subtotal cholecystectomy, which was just discussed on the general surgery communities. And I also know that there's going to be a presentation at the Clinical Congress this year. So the question is very interesting because a lot of people are asking, so how do I do it? And what's this business about a fenestrating or reconstituting subtotal cholecystectomy? Can you help us with that?
Maybe. Actually, I'm a reasonable fan of subtotal cholecystectomy. I think we see a lot of patients here with, delayed presentations and coming in days into it, and you get in there and it's hard. And, your choices are, put a tube in it and back out, or convert to open, or do a subtotal. Well, converting to open is depending on who you are, not necessarily making the operation any easier. Again, the experience of our trainees with open cholecystectomies is not broad, right? And so I think in a lot of the hands for our trainees that a subtotal is actually a safer option. The way I do it is I usually just start up at the top of the gallbladder and just split it down the front. And then you can just keep following it down the lumen and just, split the front of the gallbladder, just sort of bivalve it. And then I take it down basically as low as I get comfortable. And usually you can tell where the end of the gallbladder is from the inside. So you get in the lumen and just go straight down the anterior wall and till you get down to the bottom. And then I just take the back wall off and take it out. I usually just leave the cusp of the gallbladder open. I know some people talk about sewing it up. I will say most of the time when you're doing a subtotal, they're so inflamed that there's very little back drainage from the cystic duct. So I just leave a drain in there and leave the bottom of the gallbladder open, and almost never do they have a persistent bile leak.
Okay, and if they do, you do what?
I wait. I think patience is a good thing. And usually if you wait a week or two, they will usually stop and dry up. If you wait a couple of 2 or 3 weeks and they're still putting out 300 mLs of bile a day, then I think an ERCP is helpful. And usually they'll stop if you ERCP them and drain them internally. But they usually never drain any bile. And even if they do, it usually stops after a few days because it's a low pressure system and usually it'll stop on its own.
Do you cauterize the remaining mucosa that you leave in the gallbladder bed?
Yeah, if I can clearly see it and I'm happy with it.
Well, you mentioned baling and putting a tube in. What about percutaneous cholecystostomy? There's some question about whether that should ever be done because it's more morbid than trying to do a lap chole.
We are using it less and less because I just think it just delays the question. And then you still got a hard gallbladder. Even if you put a lap chole and they respond well, a couple months later, now you've still just got a hard chronic cholecystitis to do with a tube in it. So we're doing them less and less. I think it's the rare patient that has big distended gallbladder is clearly not an operative candidate. So pretty much the only ones we're doing now are patients in the cardiac ICU that are on ECMO that are not operative candidates. But even most of the frail elderly patients, it's either they should respond well to antibiotics and medical management, or you get them in the OR and do a subtotal cholecystectomy.
Let's stay with the biliary tree, and how about biliary pancreatitis? Clear case, bilirubin is 1.5, epigastric pain, known gallstones. How do you manage that patient?
I think if you just play the numbers, at the vast majority of time, the gallstones have already passed by the time you're seeing the patient with biliary pancreatitis. So we rarely do ERCP during acute biliary pancreatitis. I think the only time we would do is if the trends in their LFTs were going the wrong way. So if their bilirubin starts going up, then that would be somebody we would look at trying to clear the ducts. But it's never really been shown to affect the course of their biliary pancreatitis.
So you put them in the hospital, I suspect, and make them MPO, and the next day they still have epigastric pain, but their bili is now 1-1. Is that somebody you take to the operating room?
Most of the time they've had a CT scan, right? It's done before you're consulted. So again, assuming there's not horrific, rip-roaring pancreatitis and there's just a little, mild edema or something, I think most of the data would say we're probably too conservative. I think there's still a lot of this, wait until their enzymes normalize and their abdominal pain's going away. I think most of the data would say, short of the patient not getting worse in the first 24 hours, that we could probably take some of these people with a little, as you said, epigastric pain and a relatively normal CT scan. I think the data would suggest we could probably be more aggressive about operating on those people. It's hard. We're still in that wait 2 to 3 days until their pain's better and their, wide pace is normalized. But I think we could probably speed that up quite a bit.
In your world, they still get operated on the same hospital admission. Fair?
We try. Again, same thing. If you look at that data, a lot of it is there is some recurrence rate, right? But a lot of the data about why you should do it on this admission really is some of it's a convenience issue. So in losing patients to follow-up. So again, if somebody has a classic episode of gallstone pancreatitis, they feel better, within 24 or 36 hours, and you're sitting around with number 18 on the wait list case, and the patient lives close by and is reliable and says, hey, can I come back in 2 weeks for an elective lap chole? There's a lot of those people we will let go home with a scheduled OR case in the next few weeks. I don't think you have to do it like immediately, but you certainly don't want to have them tell them you're going to do it in 6 months. So I think there's we try to do them on the same admission, but once in a while it's just the timing's tough, so we will let them go home and have them come back in a week or two for a truly elective lap chole.
And is this an indication for an intraoperative cholangiogram?
Again, I am not an intraoperative cholangiographer. Some of it's just I didn't do it when we were doing open choles, and so they didn't really change my practice when we went to laparoscopic cholecystectomies. And it's actually in California, it's particularly challenging because the physician has to have a fluoroscopy license to do intraoperative cholangiogram in California. So it's a challenge for the physicians to maintain the license and all that kind of stuff. So, but again, if the trends are normalized, and most of the data would say if where you're suspecting they could have choledochal lithiasis either based on pancreatitis or labs, the data would say if all those numbers are trending in the correct direction, then your risk of having a positive cholangiogram is less than 10%. And so you start, weighing the false positive rates from cholangiograms with that, and it's I think in that case you get into the area where you have diminishing returns.
Well, let's talk about one of the favorite consults that as an acute care surgeon we get, and that is the patient arrives in the emergency department with a little fever, a little white count, but his main complaint is that his butt hurts. And the call is, we need you to come down and take a look to make sure he doesn't have a perirectal abscess. And do all those patients go to the OR for an EUA, or can you sometimes manage a proper exam in the emergency department?
Yeah, so I think there are some patients that just clearly have a superficial perianal abscess that's just sitting there waiting to be IND'd that you can do at the bedside in the ER. And, and that's not an insignificant number of these people, and it's usually pretty straightforward and it's obvious when you look at them. I think the more problematic ones are the patients you describe with fever and pain whose external exams relatively normal. Then, those are people that probably do deserve to have a exam under anesthesia. And
you find that they have an ischiorectal abscess. Let's talk about that first. How much trouble do you go to find a fistula as the cause at that drainage procedure?
If I'm going to be honest, none. For me, you drain them, right? And you take care of the abscess, you drain it. I think it's for educational purposes. We'll frequently, do a scope anoscopy to see if there's an obvious hole, but most of the time you don't see it. So usually I just deal with the abscess and drain it, because many times these people will just heal and that'll be the end of it.
That's being honest. I'm sure that's what a lot of us do. Let me ask you, because this is a constant battle between our colorectal surgeons and those of us who actually see these patients, are you a packer of that cavity, or you just put a simple drain in that cavity?
I usually just lightly put a little dressing in there. I always teach the residents there's a difference between dressing and packing, right? You pack a wound for hemostasis.
Yep.
Stop bleeding. You dress a wound to drain pus. And so I usually just put a little light dressing in there to keep the skin edges open, and then just have them take it out the next day. And then usually that's the end of it. They can just keep it clean and get in the shower.
So you haven't looked for a fistula. The patient goes home. Do you schedule them for anoscopy to evaluate for a fistula as an outpatient then?
No, I usually wait and see what happens, because half of them will heal it up and never have another problem, and then some of them will present back with a fistula.
And in those that come back, do you look for that fistula at that drainage procedure, or still wait and do an elective fistulotomy at a later date?
I'm going to be honest with you again. If they come back, then this is usually where I'll send them a colorectal surgery. It's not a complicated operation, but the last thing you want to do is, mess up somebody's bottom end. And so there are some times when I think, it's good to get your friends involved and, start talking about cutting on people's anuses. That's one of the ones where I'm like, okay, I've kind of reached my limit here.
Final inquiry into this area of the body. And it's been a long time since I saw one, but it was just a week ago that we had one, and that is a supralevator abscess. You got any keys of how currently they're usually recognized on CT scan as ours was. How do you treat that?
Again, in our honesty mode, those are ones that just confuse the heck out of me. And those are the ones where I will consult colorectal surgery. I get confused, and I am, really nervous. That's one thing where I'm nervous about missing it and not getting it drained properly, because they can get quite sick. So that is the one situation in these where I will definitely call colorectal surgery and ask them to give me a hand.
I'm dealing with our colorectal CSAP author next week, and I will touch base with him on that. So, any thoughts about if you have a patient with IBD that comes in with perirectal abscess, or is that another consult to colorectal?
Oh yeah, that's a whole nother problem, right? Because again, same thing. Like, the last thing you want to do is start INDing Crohn's disease, thinking it's a simple abscess. So, I think those ones that definitely require some special attention. I think just philosophic statement. This is one of the things about, acute care surgery, which is it's great to be a jack of all trades, but you also have to recognize, like, what are your limitations and when do you need to call your friends and get some help. And you can't just be, doing everything to everybody. So, when you start talking about dealing with people's bottom ends and risking incontinence and all that kind of stuff, man, I'm going to call one of my colleagues in.
Good advice for everybody who's listening. Well, let's talk about another consult that we get, which is necrotizing pancreatitis. So you have a patient who comes in with an alcohol history, has acute abdominal pain, maybe fever, white count. Take that patient and run us through your management scheme.
Yeah, I think you can sum up the management scheme on these patients with one word, and it's wait, W-A-I-T, right? I think more and more of the data is now showing that for these people, like, you wait. And when you're getting a little impatient, you wait a little bit more, because a lot of these things will consolidate down, and you may have to debride them. But if you can drag your feet and get that out to 2 weeks or more, the extent of the debridement and the impact of that gets to be quite a bit less than if you're doing that initially in that first week or so. So, a lot of this is, again, supportive care, hydration. I think we can probably be a little bit more aggressive about enteral nutrition in these people than we have been in the past. But again, as far as the, managing the necrosis, it's really just trying to wait and try to get this as consolidated and as localized as you can.
Now, all the data says we should be sticking catheters in them and stepping up the size of the catheters. Are you not a fan of that?
Again, once you make that decision to intervene, right, at 2 weeks or whatever, then our group here, there's kind of two ways that I might attack them. One might be the step-up approach, which works well. We've had a lot of experience and success with transgastric approaches. So coming in, with a laparoscope through the stomach and into the lesser sac and debriding them transgastrically with pretty good results and pretty minimal morbidity for the patient.
You place a stent, I'm then assuming?
You basically put a trocar into the, anterior wall of the stomach, open up the back wall, and debride them through the back wall of the stomach.
So it's just a one-time debridement? You don't try to leave a stent and then do repeated debridements?
Yeah, it's usually repeated debridements. It might take one or two times to get in there, but yeah.
And have you done any of the retroperitoneal dissection through the endoscope or the laparoscope?
Yeah, I have not. We've had some of our HPB surgeons will do that, right? They'll get a percutaneous drain in and do sort of the classic step up, and then eventually follow that tract in with a scope usually through the left flank, and just do a retroperitoneoscopy debridement through that established tract. And I think, again, both those approaches, either the step-up and retroperitoneoscopy and the transgastric stuff, certainly are way less morbid than an open pancreatic debridement.
I've got one conundrum that's related to acute care surgery that I'd like you to weigh in on, and that's large bowel obstruction. Is that a condition that ACS service should be handling, or should those usually be managed by our colorectal surgeons? And I'm talking mostly when it's pretty clear that you've got a cancer that is causing the obstruction. How do you handle that at your institution?
Yeah, again, I think some of it gets back to the acuity of the situation. So, at our place, we split call, so we do an even-odd kind of thing, and for colorectal cases and emergencies. And again, if it's a complete obstruction and the patient needs to be decompressed, then I think that's reasonable for the acute care surgeon to handle it. If it's I think the key thing is if you're going to do that and the patient does have malignancy, then you got to have a way to make sure that patient gets tied into the cancer center and multidisciplinary care that needs to be undertaken for that patient, because this operation is frequently just the first step. And again, it's one of these things you got to, put your ego aside and do what's best for the patient. And so I think it's going to be very situational depending on your institution and what the resources are and what's the acuity of the need. I think a lot of these patients have left-sided lesions, can be stented and prepped and having a semi-elective resection. So I think there's just, again, you got to know what are the resources in your place and make sure your decision's always sort of based on what's the right or best thing for the patient, not whose turf it is and what day of the week it happens to be.
Another bit of good advice. Let's switch a little bit and use your trauma training as an acute care surgeon. And first, I know is a favorite topic of you, and let's talk about blunt thoracic aortic injury. So who gets treated non-operatively these days?
Well, I think, pending a really scary-looking CT scan, I think most everybody's going to get managed non-operatively initially. I think there's occasional CT scan that looks pretty ominous that should get stented right away. And I do think there's a few clinical situations where you might want to stent somebody right away. The tricky one being somebody where you're trying to, if you're doing non-operative management, this is really, blood pressure and heart rate control. On the other hand, if the patient also has a head injury, you don't want their blood pressure to drop. So there are occasional situations where you have competing goals, and getting the TEVAR done early kind of simplifies the care, right? But, again, that it's unusual that you need to do the TEVAR at 2 in the morning unless the CT scan looks really scary. So most of the people are going to be put in blood pressure and heart rate control initially and then sort of get their TEVAR in the light of day. So I think that's usual way we'll do it.
All right, now you opened the door, so I'm going to walk us through it. So that patient who comes in with that aortic injury and that traumatic brain injury, I agree, and you've got competing goals in non-operative management. But if you put the TEVAR in, you have to put them on those nasty antiplatelet drugs, don't you?
Not necessarily, not or at least not right away. Our people have been willing to hold off several days on that, and usually, by 72 hours or so, the head injuries kind of settle down, and you're out of that window. If it's progressed or your CT scans gotten worse or not. So usually by that time you're in that window where antiplatelet agents are probably okay. So, and again, I think in the aorta, that high flow, big graft, high flow, I think that antiplatelet agents are way less important than, coronary stents or distal grafts.
So in your world, the use of the antiplatelet drugs really create minor issues in that patient with a combined aortic and brain injury.
Correct.
Okay. And is the open operation dead?
Pretty close. I can't remember the last time we did one. I think it would have to be somebody almost with an impending rupture, because even now, the ability for people to get access and get stents deployed with a wire is almost just as fast as an open operation. So I can't remember the last time we actually did an open repair. It's probably been at least 8 or 9 years.
And what about patient age? An adolescent who comes in with a bad thoracic aortic injury, do they get a TEVAR?
So interesting. We've had 2 that I can remember, like 15-year-old boys. Now, both of them were adult-sized human beings. So it was the less of a controversy. But again, in terms of like FDA approval and off-label use, it was a kind of a big issue. And, so I do think it's a size thing. So if there are teenagers and adult size, I think it's clearly the right thing. And, you talk to parents about this and you're like, well, it's not FDA approved, but we have a endovascular option that has basically a 0% paraplegia rate, or we could do, an open operation that has an 8 to 10% paraplegia rate. Well, you know what they're going to pick every single time, and it's what I would pick for one of my kids. So, but there are some, legal and FDA supervising issues of putting a device in a kid. Now, what happens if you have like a real 12-year-old that's got a small aorta? That would be way more challenging. Luckily, we haven't faced that one, but I think in those kids, if you're talking about small aortas, you're probably going to be stuck doing an open procedure.
What about a small woman?
It can be challenging, right? If you get some of these petite ladies that have a small aorta, I think most of the time we've been able to, make it work, because I think a lot of the aortic grafts are reasonably well sized, but it can be an issue with getting access too.
Do we know enough about long-term follow-up on these patients that we're not creating a group of patients who are going to have problems that we just don't know enough about yet?
Well, there's still that risk. We've been doing endovascular grafts long enough, that we should start to see some issues. But yes, what about aneurysmal degeneration? And I haven't seen any data yet on 5 or 10 year follow-up on some of these patients.
And do they all stay on antiplatelet drugs as long as they've got their graft in?
I don't know. I don't know what our practice is here. I don't think so, but I think they stop them after a year.
Well, the second topic is rib stabilization. We had lots of discussion in all of the CSAP committees, I think, on this, and I wasn't sure that we're all on the same bus. So I'd ask you first, do you have any set of indications that you could identify the ideal patient?
Again, if we're going to be data-driven right now, the indication for rib stabilization is a patient with a flail chest who is stuck on a ventilator.
And how many days stuck?
Well, that's a good question. But I think you're probably talking at least 4 or 5 days, and it doesn't look like they're going to be able to be weaned in the short term because of this chest wall injury. That's the clearest data. After that, it gets a little tough to know. I think it's an unanswered question, and I think there's 2 variables. So one is we don't even really have a good idea of what is the natural history of somebody with multiple rib fractures in 2019, right? Our pain management's changed completely. We do multimodality pain management on these people, which we weren't doing 10 years ago, right? So everyone with rib fractures committed to our place gets put on a lidocaine drip. They get oral gabapentin, and they get, round-the-clock Tylenol, minimal narcotics, and, we do that and try to get them out of the hospital. But the question is, what do those people look like at 3, 4, 8 weeks later? How many of them are not taking narcotics? How many of them are sleeping well? How many of them are back to work? We really don't know the answer in 2019. If I'm going to plate somebody's ribs, I have to know that I'm going to, short of that, foil chest and being on a ventilator, I kind of know that I'm going to impact their normal course. So we're actually starting started a prospective observational study. We've got about 70 patients enrolled where we're actually following them for 6 months and just trying to figure out those answers, like who's taking pain meds, who's sleeping through the night, who's back to work, when do they return to their normal life, and would rib plating significantly change their trajectory? I think if I had 5 rib fractures and you told me I could have an operation and I'd feel a lot better in 3 days, or I'd have to, be off work and take narcotics for 3 weeks, I'd probably have an operation. But I don't think we know the answer. So that's one variable that's out there that I think needs to be addressed. And then the other issue is I do think the long-term answer is going to be absorbable plates. We've done a number of these rib platings and everything looks great, and then the patient comes back a year later and the screws are backing out and the plates are loose. And I think it's tough because you've got a constantly moving chest wall with a rigid structure stuck to it. And the biomechanics of that over time just don't quite work out. So actually, a rib plate's a permanent solution to a temporary problem. You need something to stabilize that rib for, 4 weeks or 6 weeks until the healing starts. And then you don't really need the plate after that. So I think bioabsorbable plates are going to be the answer. And I think my threshold for operating would be a lot lower if I had an absorbable plate that would improve the patient's pain.
Let me go back to that patient who is stuck on the ventilator for those 4 to 5 days. One of the comments that some of the committees made was, okay, so they look like they're developing a pneumonia. Do we go ahead and rib stabilize them under those circumstances? How do you look at it from that standpoint?
Yeah, I think the question is, hardware infection always gets people pretty nervous, and if they are stuck on a ventilator, they develop pneumonia, then they're likely going to be on the ventilator even longer. But now, if you suspect pneumonia, do you put hardware in the face of potential, infectious source going on? I think it's really very unlikely that a plate's going to get infected, and I think even if it does, it's not quite the same thing as saying have an infected hip replacement, right? So if you get an infected plate and you have to take it out, it's not the worst thing. I don't know that I would let pneumonia deter me from plating somebody if I really thought they were going to need to get off the ventilator.
And you mentioned absorbable plates. I was going to ask you about those. Have you used any of these that are out in the marketplace right now?
Not yet. So I think that's the next thing we gotta look into.
And then you mentioned the plates loosening. We have seen some of our patients come back with pain as a problem when they didn't have it initially. You have any feeling of how often that becomes the problem and then begs the issue, do you remove the plates?
Well, again, it's one of those things I haven't seen anybody publish their 6-month or 1-year follow-up of rib fractures and plating, right? And how often do you have late complications, right? So we frequently focus on, 30 and 60-day outcomes, but this is something you really need to look at, a year later, and how many of them need to come out. And I suspect that number is higher than people want to admit to, based on our experience. And you might argue that, well, maybe we didn't get the plates on and we didn't get our screws bicortical, who knows. But I do think that it's probably a higher number than people want to admit to, and we probably don't have great 1-year follow-up. So, again, it's not a huge operation necessarily to take them out, a subcutaneous operation, but, again, you're committing the patient to another procedure and, whether or not they have issues of chronic pain or the like. So, again, it's a permanent solution to a temporary problem, and I actually think that I think in the long run some sort of absorbable plate with some sort of temporary fixation is really going to be the answer.
Let me ask you, from your location at Stanford, some of the radiologic literature, at least I've seen, is talking about 3D imaging, using AI to decide what that ideal patient looks like and whether or not the chest symmetry or geometry is what it should be. You got any fancy engineers at Stanford that are working on something like that?
No, we haven't, but that's a great idea. Like I say, we have just started this prospective study, and we've enrolled about 70 patients, and we're going to keep enrolling them, and we're following them for 6 months. These are all non-operative patients. And the interesting question will be, like, again, if we do find a certain group of patients aren't doing well, 2 or 3 months later, can we correlate that with the 3D reconstruction of the original CT scan? And, how much overlap or deformity or chest wall collapse do they have? That's a good question. We're going to have to incorporate that, John.
Okay. You can list me as a consultant, okay?
Perfect.
Well, David, it's always a pleasure to sit down and talk to you about any of these topics, but I see our time is about up, and I give everybody the chance for any last thoughts about CSAP and CSAP Audio Companion. And for you, I would add this phrase, especially given the changes in MOC, or as the American Board of Surgery describes it now, CCP, or Continuous Certification Program. How do you think this is going to fit?
So I think CSAP is going to have the next evolution, right? Surgeons are inherently competitive, A-type personalities, and everybody wants to do well, and everybody wants to be smart for their patients, right? So I actually think that the two systems will work well together. I think CSAP's probably going to become a little bit more modular to match what people are doing in their practice. I think the whole push for the change in the CCP for the board was, I am a trauma acute care surgery. I don't do breast surgery anymore. Why do I have to answer breast questions on my recertification exam? It's not relevant to my practice. And so that's the whole change in the structure of the recertification or MOC or CCP was to try to make it more practice relevant. That was the big criticism and concern. I think CSAP can do that too. Like you can have CSAP and make it practice relevant for you and study the parts that are important to you and interesting to you and helpful for your patient care that you're providing. So I think it's just an evolution of both systems, and I don't think they're mutually exclusive. I think they're complementary.
Well, again, I thank you for your contributions to both programs, and I thank you for your insightful comments as usual.
Thanks a lot.
That's it for this category of the CSAP 17 Audio Companion.